Hello, everyone. My name is Dr. Robin Harris. I'm a pharmacist by training and currently a medical science liaison with Insmed. Thank you to California Thoracic Society for the opportunity to share this presentation with you on addressing unmet needs in NTM lung disease. Let's start by looking at some epidemiological data and the impact of NTM on various outcomes. Based on data from 2015, the incidence of NTM lung disease is 4.73 per 100,000 person years, and the prevalence is 11.7 per 100,000 persons. These data are a bit outdated, and more recent data indicate that the incidence and prevalence of NTM lung disease are on the rise. NTM lung disease is a chronic and progressive condition, and it can be debilitating. It generally occurs in vulnerable patients with certain underlying risk factors. It's associated with an increase in morbidity and mortality, and patients with NTM lung disease can have a lower quality of life, and NTM lung disease can have a significant economic impact on the healthcare system. The pathophysiology of NTM lung disease can make it difficult to treat, and this slide shows various contributing factors to that challenge. First, NTM mycobacteria are a diverse group of organisms that are ubiquitous in the environment. They can be found in water and soil sources, including plumbing pipes in buildings, shower heads, hot tubs, potting soil, among other sources, and they are transmitted to humans by inhalation of contaminated aerosols. There are many species of NTM that have been identified, and they vary in their pathogenicity. The most common organism causing NTM lung disease in the United States is Mycobacterium avium, and I may sometimes refer to this as MAC lung disease throughout this presentation. So NTM and MAC here will be used interchangeably. In addition, NTM can create and exist within biofilms, and they can invade and live in alveolar macrophages, thereby subverting the susceptible host's cellular defenses and lead to chronic infections. In order for individuals to develop clinical NTM lung disease, one has to be a susceptible host and be exposed to the NTM organism. As I mentioned, NTM organisms are ubiquitous and found in various soil and water sources. What makes for a susceptible host, however, has multiple contributing factors which are illustrated on this table in blue or to the right of the environmental exposure list. The first bucket is labeled structural lung disease. This includes bronchiectasis, COPD, cystic fibrosis, and loss of ciliary function. The next risk factors are physical characteristics, which include being tall, elderly, female, having a low BMI, or thoracic skeletal abnormalities, such as scoliosis or pectus excavatum. Next, we have genetic susceptibilities, and these include CFTR mutations and mutations affecting immunologic function, ciliary function, and connective tissue. And lastly, we have immunosuppression, which includes primary immunodeficiency, systemic illness, and immunosuppressive therapy. These attributes likely play a key role in the pathogenesis of NTM in the susceptible host. NTM lung disease progresses in most patients who go untreated. Natural history studies indicate that approximately 60% of patients who meet the ATS, ERS, ESCMID, IDSA criteria for NTM lung disease who did not get treatment had disease progression. Furthermore, disease progression can have an effect on healthcare resource utilization, lung function, and mortality. Studies have shown that individuals with MAC lung disease who don't receive treatment have more hospitalizations, more outpatient visits, and use more prescription medications. They also have significant decreases in FEV1 and higher all-cause mortality compared to patients who do get treatment for MAC lung disease. The patient journey to diagnosis of NTM lung disease is often long, and data presented by Wang in 2021 found that a late diagnosis is associated with a 24% increased hazard for all-cause mortality in patients who have underlying COPD. Another study presented by Dr. Winthrop at ATS in 2022 showed that patients who received early treatment with antibiotics had a significant reduction in all-cause and respiratory-related hospitalizations and emergency department visits at year 2 compared to baseline. For those patients who received delayed treatment with antibiotics, they saw an increase in all-cause and respiratory-related hospitalization burden at year 1 and no difference in these measures at year 2 compared to baseline. According to guidelines that we'll discuss a bit later, in order to have a confirmed diagnosis of NTM lung disease, 3 things have to be present. Sputum cultures that are positive for an NTM organism, typically MAC, radiographic evidence of the disease, usually described as tree and bud sign and/or cavitary disease, and NTM symptoms reported by the patient. So it probably won't come as a surprise that the treatment goals for these patients include microbiologic conversion, radiographic improvement, or symptomatic improvement. Now, with regard to microbiologic conversion, the goal is to achieve culture conversion to negative for 12 months while on therapy. Radiographic improvement can be complicated. The goal is to see improvement, but oftentimes the best outcome that can be achieved is halting or slowing progression of lung decline, as these patients tend to have concomitant lung disease that can also have an impact on that. Symptomatic improvement tends to be the most important goal for patients. They want to feel better and have an improved quality of life. The goal is to see improvement in symptoms within 3 to 6 months of initiating treatment. Achieving this goal can also be complicated by progression or exacerbation of pulmonary comorbidities that the patient might have in addition to their NTM lung disease. Now that we've reviewed the goals of treatment, let's turn our attention to how to treat NTM lung disease. The most current guidelines for treating NTM lung disease were published in 2020, and this chart summarizes the recommendations for initiating treatment for MAC. You will see here there are recommendations for initiating treatment in patients with nodular bronchiectatic disease, as well as for initiating treatment in those with cavitary disease, which is deemed to be more severe. For nodular bronchiectatic disease, the recommendation is to start a triple oral antibiotic regimen given 3 times a week that consists of azithromycin, ethambutol, and rifampicin. The recommendation for cavitary disease is to use the same triple drug oral regimen on a daily basis, with addition of intravenous amikacin given either 3 days a week or on a daily basis. You will note that clarithromycin is an option on this chart, as is streptomycin. These agents can be used, but azithromycin is preferred over clarithromycin for a couple of reasons. 1, there are fewer drug-drug interactions with azithromycin. And secondly, clarithromycin is given twice daily, whereas azithromycin is only given once a day. So this could potentially improve adherence to the treatment regimen. Streptomycin is an option, but it is not readily available in the United States. Macrolides are the cornerstone of treatment for this disease, but NTM can develop resistance to macrolides, so we use the second 2 agents in the regimen as companion drugs to help prevent resistance from developing. Development of resistance results in fewer treatment options for the patient and may lead to treatment failure. Ethambutol is considered an important companion drug as it protects against acquired macrolide resistance. Alternative MAC companion drugs include amikacin and clofazimine, and these can be used if the patient cannot tolerate ethambutol or rifampicin. Rifamycin should not be used alone as a single companion drug to the macrolide because there is a drug-drug interaction and it can decrease macrolide levels. Fluoroquinolone should not be used together with macrolides because that combination is associated with development of macrolide resistance. The guideline suggests susceptibility-based treatment for macrolides and amikacin be initiated over empiric therapy as clinical outcomes are correlated with MAC susceptibility to those two agents. The probability of culture conversion in patients with MAC lung disease on treatment for 6 months or longer is highest in patients taking a macrolide plus ethambutol with or without rifamycin. As I mentioned, ethambutol is the more important companion drug to protect the macrolide from developing resistance. And as I also mentioned earlier, rifamycin should not be used alone with a macrolide because it can reduce its efficacy and may contribute to resistance. So this begs the question, is rifamycin really necessary in the treatment regimen? Here is a study that looks at that question. What was found in this review was that the combination of macrolide and ethambutol plus or minus rifamycin were essentially the same with regard to culture conversion. The macrolide plus rifamycin alone was better than a macrolide alone, but not as effective as the macrolide combined with ethambutol. These data are preliminary, and there are studies being done currently to assess the need or benefit of rifamycin to the treatment regimen. Adherence to guideline-based therapy can have an impact on outcomes for patients with NTM lung disease. It may reduce medication intolerance as well as poor disease outcomes. It may significantly improve the odds of cure, as was shown in a study published in 2021 by Dr. Abate. In the United States, guideline-based therapy is associated with lower all-cause hospitalization risk, which you see here in the graph on the right. This was work done by Dr. Maris that found that 28.8% of patients treated with guideline-based therapy were hospitalized at the 2-year evaluation point after diagnosis, compared to 43.5% who were hospitalized in the non-guideline-based therapy group and 41.7% who were hospitalized in the untreated group. Regardless of these data supporting adherence, a survey of European patients with NTM lung disease reported that only 9.2% of patients received more than 6 months of guideline-based treatment. Looking at that same study done by Dr. Maris, we just saw on the previous slide, they further evaluated healthcare expenditures associated with treatment of NTM lung disease. And what was reported here is that the guideline-based therapy group on the left used less healthcare resources compared to the non-guideline-based therapy group in the center and the untreated group of patients on the right, thus concluding that guideline-based therapy is associated with lower healthcare costs compared to non-guideline-based therapy. MAC lung disease can be challenging to treat, and data show that 24% of patients with treatment-naive disease failed to achieve sputum culture conversion within 12 months of treatment. In this study by Moon, 93% of patients with treatment failure did not convert by month 6 of treatment, and 7% of patients with treatment failure had converted by month 6 of treatment, but then had recurrence of MAC by month 12. It is suggested that patients be evaluated after 6 months of initial treatment because if they have not culture converted by then, it may be a reliable predictor of treatment failure at 12 months of treatment. This is important to keep in mind because data suggests that patients with refractory NTM lung disease have an increased disease burden. They are more likely to have a lower BMI, reduced lung function, and fibrocavitary or cavitary disease, and those data are represented here in this table. Also here in the graph on the left side of the slide, you see that patients with progressive disease have an all-cause mortality rate that is 3 times higher than those without progressive disease. So the disease burden is increased in progressive and refractory NTM lung disease. There are guideline recommendations for treatment of patients with refractory MAC lung disease. Initial therapy is a 3-drug combination regimen. If still culture positive at 6 months, the guidelines recommend reassessing the treatment plan. There are some factors that have been identified that contribute to treatment failure. These include discontinuing treatment early, prescribing an inappropriate antibiotic regimen, medication side effects and poor adherence to the regimen, and emergence of macrolide resistance. Completing the recommended treatment is often difficult for patients due to these contributing factors, including side effects and the prolonged duration of treatment. Earlier in the presentation, I mentioned that patients who develop resistance have fewer treatment options and less favorable outcomes. This slide shows a comparison of culture conversion rates between groups of patients who are sensitive to the macrolide and those who are not. You see that in the 2 studies on the left, these are patients who are resistant to macrolides. And 15% of patients in the MOON study had culture conversion within 12 months of treatment, and 26% of patients in the Griffith study converted. Compare that to this data on the right side, where patients are sensitive to macrolides, and we see in the Wallace study, 86% of patients converted, and in the Zhang study, 76% of patients on daily treatment converted, and 67% of patients on intermittent treatment converted. So it appears that the chances of culture conversion are increased in patients who are sensitive to the macrolide therapy compared to those who are resistant. I mentioned earlier that a survey showed that only 9.2% of European patients received guideline-based therapy for their NTM lung disease. And here we see data that show that only 51.1% of Medicare patients with bronchiectasis received guideline-based therapy for newly diagnosed MAC lung disease cases. Furthermore, in the 48.9% of patients who did not receive guideline-based therapy, 29.4% of them were prescribed regimens associated with development of macrolide resistance. We see 22.9% were prescribed a macrolide and a fluoroquinolone, and 6.5% were prescribed a macrolide and rifampin without ethambutol. These data suggest that healthcare professional adherence to treatment guidelines for MAC lung disease is low, and that suboptimal antibiotic regimens are commonly prescribed. Looking more closely at the data presented by Ku, we see that the 51% of patients who were initially treated with guideline-based therapy, about 41% of them continued on guideline-based therapy at the 6-month point, but only about 18% remained on guideline-based therapy at 12 months, and even fewer remained on guideline-based therapy at month 18. The author suggested one reason for premature discontinuation of treatment may be due to drug-associated adverse events. Also, compliance may be an issue due to the long duration of treatment required, especially for older patients. Factors that are associated with improved patient outcomes include earlier diagnosis and initiation of treatment rather than taking a wait and watch approach, prescribing appropriate antibiotic treatment at initiation of therapy, evaluating for refractory disease after 6 months of treatment, intensifying the guideline-based regimen for refractory disease, and patient adherence and completion of the guideline-based regimen for 12 months post-conversion. In summary, the unmet needs in diagnosis and treatment of patients with NTM lung disease are outlined here. There are delays in diagnosis and treatment, which may lead to worse outcomes. Healthcare professional adherence to guideline-based therapy is low, and current real-world treatment patterns are suboptimal. Completing the recommended treatment is often difficult for patients due to adverse effects of multi-drug macrolide-containing regimens, and treatment failure occurs in about a quarter of patients following 12 months of treatment. With that, I'd like to say thank you for joining me today. If you have any questions, please feel free to contact me at robin.harris@insmed.com.